In terms of the latest FLT3 data, I would say people are focusing on mechanisms of resistance, particularly focusing on the latest drug, Gilteritinib. Some initial studies looking at subgroups within the large clinical trials that got Gilteritinib approved, the Admiral study, the Chrysalis study. We've identified a couple of features about predicting response. Certainly, we now know that the emergence of RAS mutations and FLT3 gatekeeper mutations will result in resistance to monotherapy with Gilteritinib. However, patients who have received prior FLT3 inhibitors, such as midostaurin or sorafenib, there was always a concern that they would not respond to to Gilteritinib, or not respond as well. And that doesn't appear to be the case. If there's a drop-off in response, it's not very much. Data that we are presenting, both Sasha Pearl and Kathy Smith are heading up these abstracts, suggest that, yes, the response rate might be slightly lower, but really not very much. They still get a fairly good response rate. So patients who are relapsing after prior exposure to midostaurin or sorafenib still can be treated with Gilteritinib. I think some interesting work is out of Brian Drucker's group out of Oregon, where they were looking at some in vitro models predicting what would result in resistance to Gilteritinib, and they noted 2 phases of resistance, and I think that's worked out clinically as well. They're reporting an early phase of resistance mediated more by the cytokine milieu of the microenvironment. So we can inhibit FLT3, but blasts within the microenvironment are protected by cytokines, particularly FLT3 ligand. And we know this is I'll call it a weakness or a problem early on. After the patient has had a response to Gilteritinib, then you get emergence of these RAS pathway mutations and gatekeeper mutations. So we have a pattern of resistance that we're examining. And so those are some of the things that are being advanced in this ASH meeting to better understand Gilteritinib, how to use it, and where we go forward and how to make it better. There's a large abstract out of the Australian Leukemia Lymphoma group reporting the results of a large randomized, or not a large, a randomized trial of induction chemotherapy with or without sorafenib. Sorafenib is one of the older generation FLT3 inhibitors that, while intriguing, much of the world is abandoning because it's not well tolerated. It's not our best FLT3 inhibitor, and we now have Gilteritinib. But this trial was started several years ago and has concluded that sorafenib doesn't work all that well for this patient population. There appears to be a hint of improvement, but the problem is tolerability and efficacy of FLT3 inhibition. When you look at the data by FLT3 inhibition, patients who had in vivo FLT3 inhibition with this drug clearly had a benefit, but there is the problem with the drug that ability to inhibit FLT3 in a tolerable fashion is just not high enough with sorafenib to move forward with that drug. And I think the only other point of interest with FLT3 are the combination studies with Gilteritinib. And so final results of Gilteritinib combined with induction chemotherapy, where we're kind of treating the patients the way we want to. They get induction with Gilteritinib, go to an allo transplant and get maintenance with Gilteritinib, or not transplant, just maintenance with Gilteritinib. So that sort of forms the early backbone of the current randomized phase 3 study. So final results of that are being reported. I think the one abstract that possibly is going to herald a new therapy, though, is in fact Gilteritinib combined with Venetoclax. So I believe Naval Daver is presenting the results from a trial that we've all been conducting for the last few years in the relapsed refractory setting, combining Gilteritinib with Venetoclax. This appears to be a very highly active regimen. A number of us are using that in the off-label setting as well because it's clearly highly effective. It's also not for the faint of heart. Patients can develop profound aplasias. You've got to be kind of at your best with supportive care and knowing what to do with the patient. But nonetheless, I think it's pretty clear we're trying to work out how to combine 2 of the most exciting agents that have hit the field of AML, Gilteritinib and Venetoclax, for this patient population.